कौन है रे आईपी वरना? विनोद? कौन है विनोद? है कौन है? हॅलो. अरे ते लाईट बरोबर आहे का बघ माझ्या कॅमेऱ्याच्या खाली, बस एवढंच बघ. हाँ. ओके ओके चलो ओके. विनोद ऑडियो चेक बराबर आहे बघ. एसी गया है, इसे बंद करो.
Good evening, Nitin bhai.
Hi, Palani, how are you?
Fine. Fine.
After a long time. I keep on seeing your Facebook, of course. So, all well at your end?
Yes, fine. Everything is fine.
Very good. We'll start in some time.
ઘડિયા કદાચ છે ને 5 મિનિટ આગળ લાગે છે.
Yeah. અવાજ કેમ નથી આવતો?
નથી આવતું?
Good evening, everyone who has joined. I think there was some confusion in the message because I saw in the Gujarat group it was saying 9 o'clock, but all over other parts and Mumbai it has been saying 9:30. So that's the reason why the host is still not there. So please hold on. We will start as soon as Dr. Jagruti, who is the moderator, will join. So I think some two different messages have gone. I don't know how that has happened, but I believe it is 9:30 and not 9 o'clock. So just hold on. Dr. Jagruti will join, so we will do some informal chit chat till then, till the time we actually start. Sorry for the confusion. Anyone knows who is Dr. Gaurang Oza?
Yes, I know.
રમેશભાઈ એને ફોન કરે ને વારંવાર એ અનમ્યુટ કરે છે ને પછી એ લોકો આખું ફેમિલીનું બધું બેકગ્રાઉન્ડમાં જે અવાજ રાખે
કહી દો કે
કહી દો ને એને કહો કે કઈ વાત કરી ત્યારે કરે ને તો પછી મ્યુટ જ રહે. થેન્ક યુ.
Good evening, Rajesh.
Hi, good evening, Palni. Good evening, Nitinbhai.
ગુજરાત ગ્રુપમાં છે ને મેસેજ 9 વાગ્યાનો ગયો છે, ખબર નહીં કેમ.
અચ્છા. Actually, આપણે તો બધા 9:30 જ રાખ્યા હતા. કઈ કન્ફ્યુઝન થઈ ગયું.
ના પણ નીતિનભાઈ એક મેસેજ મેં ફોરવર્ડ કર્યો નીતિનભાઈ.
હા એ જ એટલે જ ડોક્ટર રમેશ બજાને ફોરવર્ડ કર્યું એટલે ક્યાંથી આવ્યો છે 9 વાગ્યાનો ટાઈમ બોલે એમ કહેવાનો મતલબ.
હા હા.
It's okay, chalo, we'll wait, not issue. Because
એક
lot of
5-10
many people.
મિનિટમાં સ્ટાર્ટ કરીએ.
હા આપણે 9:25 સુધી જુઓ ને વાંધો નહીં. જ્યાં છે એ બધાને મેં મેસેજ લખી દીધું કે ભાઈ સોરી સમ કન્ફ્યુઝન, they'll wait, it's okay.
હા.
Or they will rejoin, one of the two.
Yeah.
Jagruti has come. Because we see most of the members who have joined are from Gujarat, so that's why I realized that there is some confusion.
Good evening, Dr. Nitin Shah. Good evening, Dr. Chokhani. Sorry.
No, the confusion is because of the message, not because of your fault.
Yes,
It's
sir.
okay. Because Gujarat groups have received 9 o'clock, so most of the people joined. When I realized Gujarat child, then I saw the message. That's why I
Okay.
called you up. Then I realized actually 9:30, not 9 o'clock.
Yes, sir.
So wait for some time. It's okay.
Sir, while we have some time with Dr. Chokhani's permission, if there are anybody who wants to discuss anything, considering that we have an expert on panel and
We can discuss some vaccines.
some vaccines, absolutely. If anybody, esteemed audience and guests, if you have any questions to ask Dr. Nitin Shah for vaccines, it's like a bonus for people early bird prize.
No issues. So I think, as we have said, is at 9:30. Most of people must have just logged in, and they will probably join at 9:30. So you will wait for it. It's okay, no problem.
Nitin bhai, a question.
પૂછો.
ઇન્ટ્રોશિલ્ડ માં નીતિનભાઈ હમણાં એક પેશન્ટ ને આપ્યું હતું ને તો આપે પછી કલાકમાં હેડેક અને નોશિયા જેવું થતું હતું. Is it known? Entroshield.
Within 1 hour.
I haven't yet seen.
No, so within 1 hour means there was some contamination, something. So either at the end user's place, the spirit that he used or cleaning or something, because this is not known with any vaccine.
બરાબર બરાબર. ઓકે. ફીવર કેવું નહીં, પણ વચ્ચે એક છોકરું હતું એને નોશિયા અને હેડેક and it subsided.
So I think that's okay. That once in a while this can happen. These are idiosyncratic reaction, as we call. Most of the vaccine actually lead to this type. But so far there's no fever. The worry is less. The moment there is fever, within half an hour, you're worried about toxic shock syndrome and things like that. Then you have to be very careful.
Okay. એવામાં પછી ઓબ્ઝર્વેશનમાં રાખવું જોઈએ.
So if he has fever, definitely yes, you have to observe. It may sometimes it has happened that child takes vaccine and then the fever is there. The mother says no, morning also he had fever. She never told you. So maybe he was cooking some wire. But better to tell them danger signs, if not admit, and then ask them to come back if there's any confusion.
Okay, got it. Thank you. The other thing that we have seen is when you take Rotavac or Rotasure, the one which are not 5D, then if you keep it not in the deep freeze but in your normal first or second rack, then you have to be very careful because VVM may change color very fast. Because the cumulative time before it reaches you, you don't know. And so, I mean, I had the same problem. So I had to tell them to replace. They, of course, replace promptly. But then they say that even at your place, you keep it in the deep freeze. Okay.
But then the VVM doesn't change the color. But only thing, when you keep in deep freeze, it gets frozen. So you have to be careful when you're actually giving it to the child. You have to again thaw it. So just keep for 10-15 seconds in your palm and it becomes liquid again.
So you mean to say rotavirus vaccines are to be deep frozen?
No, only Rotavac and Rotasure, which is not 5D. The 5D vaccine is 5 degree. Whereas the other vaccine in the trial was kept frozen, and just before vaccination it was thawed and given, and the efficacy was with that vaccine. Now when they changed the stabilizer, they understood that even if it's not frozen, it remains good for 6 months. But the problem is that from the manufacturer to you, you don't know how much of this 6 months is already the vaccine has undergone exposure.
Right.
So it has happened that you keep it in 1 month and the VVM changes.
Okay.
And then if you have stock, you don't realize. So then they say keep it deep freeze, then the VVM doesn't. So the basic thing is that if the VVM changes, you cannot use it, obviously.
So sir, Rotasil is known to have thermostability where you can even keep it outside?
Exact. So you don't keep it outside, but it's stable at 35 degrees.
Okay.
The only problem is the Rotasil efficacy in South African study was good, 65%, same as say Rotavac, Rotasure in India. But the same Rotasil in India, the efficacy was just 37%. So you don't know whether 37 is right or 65 is right or is something in between. So from that point of view, that's the disadvantage of using Rotasil. Besides the volume, Rotavac, Rotasure is just 5 drops, so it's easy for the child. He usually will not vomit.
Right.
Rotasil is like 2.5 ml.
But it's tasty, sir.
You have tasted it?
No, my patients take it with a lot of.
Yeah, it must be having some sugar probably.
I guess so.
But takes long to administer. In a busy time, it's difficult in Rotasil for us.
That and
is very easy. 5 drops is easy.
Yeah, and that and a crying child, no, whether sweet or bitter, just doesn't want to take medicine. For them, it's a struggle. So you have to drop it on the chicks, and the child is struggling. You are struggling. The parents are struggling.
and the child vomits, then there's a question whether it has worked or not. So I used to like what Dr. Pramod Jog used to always tell, that for Rota vaccine, give it to the mother only to feed. Even the child vomits, so you say, you have only given, what can I do? Smart, smart way.
Sir, so which rotavirus vaccine has got the maximum, in Indian study or in Indian trials, the maximum seroconversion or efficacy?
No, seroconversion has no meaning at all, because if you look at the seroconversion with Rotatech in India is 85%, and that with Rotarix was 40%, and yet the efficacy of both the vaccine in a given country is the same. So it's not the IgL level that is important, it's the efficacy. That's why all these Rota vaccines have to undergo field efficacy trial. And if you look at the field efficacy trial in the best of the best country like USA and Europe, with Rotarix or Rotatec, it's almost 95% against unscheduled IV fluid, hospitalization, emergency care visit, etc. That in say Europe, little less developed than US, of course. So it fell to around 85%, and that in Latin America was anywhere from 70 to 85%. And that in developing countries like India, Bangladesh, South Africa, I mean not South Africa, but other African countries, is anywhere from 30 to 60%. Like same Rotatech in the Mali was 17%, statistically not even significant. And the same in South Africa was 65%. So, it's a country specific efficacy rather than a vaccine specific, because a lot of milieu interiors of the in the developing country, child's environment, other viruses fighting with the rotavirus, being a live vaccine, the micronutrient deficiency, malnutrition, all plays role in how rotaviral vaccine will work. But the bottom line is that even with, say, 85% efficacy, say in Latin America, for 100 children you vaccinated, one child benefited by less incidence of rotavirus severe diarrhea. Whereas even with 50% efficacy in the Gambia, it was 6 children per 100 vaccinated. So if you just compare the point estimates of the efficacy, you feel 85 looks so good than 50%. But number of children who will benefit per 100 vaccinated is higher with 50. That's because the sheer disease burden is so high. And these are the countries where it's not easy to give unscheduled IV fluid, admit, because healthcare facilities may not be easily available, etc. So in which case, even with a lesser efficacy, actually more children will benefit.
Sir, can I ask? I'm Dr. Nandurkar from Mehsana. Can I ask hematology?
Oh, yes. Oh, sir. I remember my visit to your place, sir.
Yes,
The
yes,
state
sir.
conference.
State conference.
So, water park.
Before 15 days, I had a child of about 6 months, male child, breastfed and presented with severe pallor. Hemoglobin was 5.2.
Okay.
Right. His RBC indices were that PCV was 11.5, MCV was 72, MCH was 31, and MCSC was 35.
35, that's high.
Yes. Later,
so, is there any history of...
just a minute. Platelet count was 1,47,000.
Okay.
PS was suggestive of dimorphic anemia.
Correct.
Right. So I suspected it to be a megaloblastic dimorphic anemia, and I started B12 injections. 5 injections were given. And at the same time, oral iron was given and folic acid. Now the patient turned up again after 15 days, just today, and he again examined. I did the RBC indices done again. So hemoglobin was same. It was 5.2, and in PCV it was same 71. MCH was 32. MCH was high 47. Right.
Correct.
And platelet count was 1,48,000. PS was done. Variety of cells with polychromasia was seen.
Correct.
And the reticulocyte count was 6%. So corrected would be about 2.5 to 3%. Right?
Did you have retic count in the first CBC?
No, I had not done retic count with CBC, so it was not done. So correct. I was confused. So what I did, I did the
No, so 1 minute. What was the RDW, red cell distribution with first time and the second time? It had RDW.
I have forgotten it, but I will tell you.
Acha.
It was on higher side. It was it was 16.2 RDW.
16.2 is not really that high. For diamorphy, it should be really very high. No, so my question, if the MCHC is high, 35 and then 45, there are 2 or 3 things. One is one is congenital spherocytosis can come like that. Other is IgM induced acquired immune hemolytic anemia, AIHA. These two can come like this.
So I did EMA study today, right? And at the same time, serum ferritin was done, and serum ferritin was 762. So it was on higher side.
Correct. Right? So this is not dimorphic.
Not dimorphic. So this is the patient. Now, how to proceed further? I have done already EMA study.
So you wait for, but I'll tell you, this is a smear diagnosis. You have to see the smear for microspherocytes. I'm sure if someone, see, your eyes will only see what your mind knows. So if you know how to see for spherocytes, microspherocyte, not micro, then the diagnosis is smear made. I mean.
But unfortunately,
is there 1 minute? Is there any history of any history of neonatal jaundice in the child? 1, 2, any history of splenectomy or gallbladder stone removal in the parents? That you would ask.
Okay.
That will help because many times it can happen that the father underwent gallbladder surgery, or mother underwent splenectomy, or someone else had similar problem, or their brother had neonatal jaundice. Everything goes unnoticed, but it's a smear diagnosis by and large. You see microspherocytes and but you have done EMA, so you wait for it now.
No? It will come on day after tomorrow.
Correct. So till then, put the child only on folic acid. Don't give iron now.
And I have not given iron. I have just put it on folic acid now.
Correct. Very good. So some of the highest MCHC you see in mycoplasma-induced immune hemolytic anemias, because the RBCs are clumped together so big that whole thing is taken as one RBC, by the counter is a mistake. So MCC is 60, 70, 80 like this. So MCHC is very high. You raise your tentacle for doing a direct Coombs test. The child had splenomegaly, little?
No, child had no splenomegaly.
No liver, no spleen. So when you come next, of course, you see the EMA that is positive. Ask family history and child history for neonatal jaundice.
Okay. Thank you, sir.
So there's a question in the chat box regarding vaccination. Dr. Gayatri is asking if a newborn has post-vaccination fever. So I assume after the birth dose of BCG hepatitis B, up to how many hours it can be because of the vaccination? And if fever persists on second day also, should we send a septic screen?
So that's in a newborn or anyone else?
Newborn.
No, so newborn, if he gets fever after vaccination beyond, say, only hepatitis B and BCG was given, or only BCG was given?
BCG and, I'm assuming BCG and hepatitis B.
Yeah, BCG never leads to fever. Oral polio never leads to fever. If it's hepatitis B, can lead to fever up to 24 to 48 hours. So you also look at the child, whether he's feeding well, and what you call sick looking versus non-sick looking. And if he's sick looking beyond 48 hours, send a septic screen. Okay. Especially if you're sure that you have taken all the precaution of asepsis while giving.
Yes.
Nitin, your personal experience with the liposomal iron.
You mean IV iron?
A liposomal oral iron nowadays coming.
I never use any of these fancy ones. We were completely fooled by, the in past the IPC molecule. IPC, yeah, absolutely. Yeah. So I used to jokingly say that IPC, that iron polymaltose complex iron, never leads to any side effect because there is no effect also.
No effect also, yes.
So I think you should stick to ferrous sulfate, ferrous fumarate, or ferrous...
Ascorbate is good also.
Ascorbate, yeah. Ascorbate is a little expensive, but otherwise is equally good. One of the three, whichever you are comfortable with. Otherwise, this colloidal iron and all those, chelated iron and all, Then you have this, I don't know, that testosterone. What is the testosterone? Yeah, after my blood. But I say without
Yeah,
doing
that's
a
okay.
test.
Yeah.
Yeah. So I said you have to do. You give to one of my student thesis, double-blind randomized control trial, not double-blind, but the randomized control. And if it's good, we will use it. First of all, 8 milligram of testosterone in one sachet, so it's expensive. Now
Yes.
they come out with I think 16 milligram, but still therapeutic. You need 50, 100 in a child who's 20 kilos. So that become very expensive then.
Nitin bhai, what about white iron? Nowadays
What
they
is
give
white
white.
iron? I've
I don't
never,
know. Some
never,
representative came and he said that ours is white iron.
I've never heard. You have to tell him what is the content, whether white or black in color doesn't matter.
No, but
Hmm.
Rarifer is available, and they say that our syrup is white iron.
Which one is that you said?
Rarifer.
Rarifer. I've never heard that brand. Maybe it's in Gujarat.
No, it is not a local brand. It is definitely a good brand. But they
Rarifer. I have heard
Rari,
Raricap, but not
no,
Rarifer.
Rarifer.
No, no. So I think it's not available in Bombay. So really, I mean, if you send me the picture content-wise, then I can comment as to what is it.
So Nitin bhai, which iron you use?
I use ascorbate without mistake, and I use always the one which is high B12 and folate, because most of the children who have iron deficiency also have other nutrition deficiency. So I use, I mean, I will take the brand name. There's nothing wrong. I use Feronia Max a lot. With that, obvious the need to keep a separate B12 and folate. The Feronia Max has 30 milligram of elemental iron plus 500 microgram of B12 and good amount 100 to 200 microgram of folic acid. So it's all in one, just one dose at night, and that's it. I think now we can start. It's 21:30.
Yes, please.
Yeah.
Good evening, friends, and thank you for joining in on this Webflix series of IIP Mumbai. You'll all agree that it's cricket season, so we thought of aptly naming it the third umpire. And who better than a third umpire being Dr. Nitin Shah for Hemat Oncology, because nobody can dispute his decision. So let's get a rapid revision of many aspects of Hemat Oncology from Dr. Nitin Shah. The way we will do this session is that there is no set PPT to be covered, no lecture by Dr. Nitin Shah or the moderator. You please put in all your questions in the chat box, and the moderator, Dr. Jagruti Sanghvi, will pick them up and ask Dr. Shah. And to set the ball rolling, she will start with one or two questions. So that's the way we will do it. And happy learning to all of us. On a different note, it is also IIP election season. So appeal to every one of us to vote, because it is our duty that we all as IIP members should vote. So please vote. Please, you can confirm here in the chat box that you have voted. And for Mumbai people, you can even put in your respective zones that you have voted. But please vote. So with that, we start with today's session, Dr. Jagruti and Dr. Nitin Shah.
Good evening, everyone. I am so glad.
I think Jagruti's internet has crashed. Oh, so far it was working so wonderful. Rajabhai, just call her, huh?
And in a cricket match, we can expect a DRS of just...
Jagruti. She's again frozen.
Sir, I'll call her, sir.
Yeah, Nehal, call her. Or you take over, Nehal, if you have any. If her internet is a problem. Jagruti, your internet is very unstable. We couldn't hear whatever what you said.
Okay, one sec.
No, now is okay, but when you started, it froze for 10, 15 seconds, 30 seconds.
Okay, now am I audible?
Jagruti, you can switch off video.
Yeah, I can do that.
No, you are on mobile internet or?
No, sir, I am on my internet.
Okay, fine. All right, okay.
Of a cable network. Okay, good evening, everyone, and I'm sorry for the goof up in the beginning itself. Doctor, I'm very glad to moderate this session with Dr. Nitin Shah as our third umpire. And as in a cricket match, we would expect a DRS of only 2 turns per team. But Dr. Nitin Shah is gracious enough to kind of grant all the DRS, that is the doctors, in this particular match today. And he's going to be answering all our questions, all the googlies that we think that we face in our practice. So thank you everyone for being together on this evening. And today's session on hematology and oncology, I am going to start off with simple queries on iron deficiency anemia first, and then maybe we can take on queries. Please put up your questions in the chat box, which we will take as and when you put it up. So sir, like when you are, normally whenever we ask for a CBC, and if we find a low hemoglobin, and if we also find a very low MCV, the doubt that we have in our mind is between iron deficiency anemia and thalassemia trait. So
Correct.
how good is Menzer index?
Correct.
And how
So I think,
definite it is?
yeah, so Jagrati is just not the Mensa index, you have to see a CBC in toto. So what do you see? You see hemoglobin which is little low. Obviously, that means there is some anemia. Now, MCV is low, so it tells you it's microcytic. Now the question is whether it's thalassemia minor or mild iron deficiency. I mean, if it is 4 gram, 5 gram with MCV of 50, it is obviously iron deficiency because you cannot have thalassemia minor having 4 gram and 5 gram hemoglobin. So if it is around 8.5, 9, 9.5, then the question comes. So one is that you look at the RBC count. If the RBC count is high, 5 million, 6 million, 6.5 million, you don't have any business to have such high RBC count in iron deficiency because it's a problem of production. So obviously, second thing is your MCV. So your MCV is very low, disproportionate to the hemoglobin. So just suppose hemoglobin is 9.5 and MCV is 56. Now that doesn't happen in iron deficiency. With iron deficiency, MCV will go down as much as the hemoglobin goes down. So with 9.5 hemoglobin, MCV will be around 67, 68. It becomes 6, it will become 50. So if you have a high RBC count and a disproportionately low MCV with a relatively normal hemoglobin, and then you look at the RDW. RDW is nothing else but what you see under microscope as anisocytosis, which means the RBC cells, are they of the same shape and size or they are different shape and size. So if you don't see anisocytosis, which means RDW is normal, this is typical thalassemia minor. So I repeat, high RBC count, a very low MCV with a near normal hemoglobin and a normal RDW. Now you look at the community, Punjabi, Sindhi, Kachi, Lohana, Bhanushali, for sure you think it's thalassemia minor. Ask for electrophoresis, you will be rewarded that the A2 will come high. We pick up several times. This is important, especially for the gynecologists and obstetricians, because if they pick up this in a mother, then they test the mother, and if the mother is positive, they immediately test the father, and if both are thalassemia minor, then you can still do the coronary sampling or the amniotic sampling and prevent the birth of thalassemia major.
Yeah, sir, absolutely. But sir, if you also have a concomitant severe iron deficiency,
right,
can that
right.
mask a thalassemia trait in?
Right. So if you have iron deficiency which is significant, then if you do your hemoglobin A2 may come borderline. So you don't know whether to call it thalassemia minor or no. In which case you always give iron first and repeat your CBC after a month or so, and that time you repeat your electrophoresis. And if it is thalassemia minor, the A2 will show up. The second thing is when you are concomitant, you give iron, the hemoglobin will become high, but will never normalize. So say you started with 8 gram, you give iron, after 1.5 to 2 months of iron, it is just there is 9. After another 1 month, it is still only 9. It's not going to 10, 10.5, 11. That you know now that the iron deficiency part is taken care. Now rest all is probably thalassemia minor. And this third thing is I normally never do iron studies of ferritin in a typical iron deficiency setup. But this is set where you have not a response which is as much as you would want with iron therapy. At least do ferritin at time and see. And your ferritin will be high. It tells you that this is thalassemia minor.
Okay, sir. But sir, then there are so many other new indices on a CBC that we see nowadays, and sometimes it is confusing. Like recently we had a discussion on mean platelet volume, MPV. We were wondering how significant it is to our general pediatric practice. So can you please throw light on those?
Yeah, so frankly speaking, what you should look at is the RBC count, hematocrit, MCV, MCH, MCHC, and you look at the mean platelet volume. These are generally available in most of the counters. Now, beyond that, you have immature reticular fraction, your immature platelet fraction. fraction, your immature granulocyte fraction, then you also have percentage hypochromic cells, and you also have reticulocyte hemoglobin content. So these are newer indices. I don't think you should really break your head, but one thing is very important is IPF, immature platelet fraction, and we can discuss that when we discuss dengue or a low platelet count, that when you have immature platelet fraction is high. So what is retic to RBC is immature platelet to platelet count. So if your immature platelet count is high, like your retic is high, it tells you that the marrow is functioning and throwing a response to the peripheral problem. So if you are suppose a bleeding, your retic goes up because the marrow is normal. Same way when you have ITP, your platelets are destroyed, marrow is normal. So marrow will throw immature platelet, your immature platelet fraction will become high. So a high immature platelet fraction tells you peripheral destruction and a normal marrow response. A low immature platelet fraction tells you that the marrow is also diseased, like say in leukemia, lymphoma, or any other aplastic anemia and such other condition. So that's an important index. The other thing in dengue, many times the parents are very worried about platelets not improving. You do a third or fourth day of admission CBC with IPF. IPF is 30, 35, 15, 20, is high. You can assure the parent that next 1 or 2 days the platelet count will start rising. So that's the advantage. Percentage hypochromic cell, reticulocyte, iron content are all signs of early iron deficiency. More of still research, I would say, rather than standard of care.
Okay, sir. So, sir, when we were just recently discussing, like before a lot more people joined in, for the sake of maximum people having advantage, can you tell us what are the different type of iron preparations that are available, and what should we actually prescribe, and what is actually the dose of iron that is tolerable at the same time effective?
Correct. So very recently, the IIP Pediatric Hemonc chapter has come out with guideline for treatment of iron deficiency, and the next guideline that will come out with is megaloblastic anemia. And we already have a book published on thalassemia. So some of you who may not have seen this, please go through that. I will tell you in nutshell. First of all, lots of iron salts available. You use one which you are understanding and comfortable with. So I use iron ascorbate. You can also use iron fumarate and iron sulfate. So ferrous sulfate, ferrous fumarate, and ferrous ascorbate. These are the only three salts that I use. I don't use any other fancy salt. The dose is 3 milligram per kilogram of elemental iron and not 3 to 6. At 3 milligram, the side effects are less and the effect is as good as 6 mg. You can even give alternate day to start with or twice a week if the child is intolerant and not tolerating, and then gradually increase. You can give the dose at night because when the child sleeps, the GI side effects are less perceived because the child is asleep. So these are the tips that I would give you, that you give 3 mg per kg, single dose at night. If the child cannot tolerate it, divide into 2 doses. If the child still cannot tolerate it, make it alternate day or twice a week and then gradually increase. And then you would do a CBC and retic at 5 to 7 days to see for reticulocyte response. It is not required to do it. In theory, you can do it, but I normally do one CBC after 1 month. It should show at least rise of 1 to 1.5 gram. Then I do at 3 months, the hemoglobin should become near normal. And then once the hemoglobin is normal, you continue to iron for at least 2 to 3 more months for the replenishment of the iron stores.
Sir, one of the oldest iron preparations that is available is colloidal iron.
Correct.
There's a question in the chat box saying how good is that and what is the dose for that?
Yes, so it is good. The dose is 3 to 6 mg per kg, but as I said, now we give 3 mg per kg. Only remember that this colloidal iron preparation, the strength is very high. So most of the ascorbate, sulfates, fumarates are 30 mg per 5 ml type of syrup, whereas this colloidal iron may be 60 like in ferrochelate, 80 like in tonoferon junior, and 250 milligram like in the syrup tonoferon. So when you calculate, you would be careful, especially the surgical friend. I mean, I've seen sometimes children having a severe toxicity because the surgeon wrote syrup tonoferon 5 ml 3 times a day. Now that's 750 milligram of elemental iron in a child who's 10 kg. That's a toxic dose. So be careful when you calculate your dose.
Okay. So, sir, in that case, do you continue the iron in the same dosage for like the entire period, or when you then want to make it like a prophylactic dose at any point?
No, so 3 mg per kg is a continuous dose till hemoglobin is normal and for at least 2 more months to replenish the store. After that, to prevent a relapse of iron because the child's iron in diet is not good, then as per our national program, what you call NIPI, the National Iron Plus Initiative, you give prophylactic iron doses which are much lesser than the therapeutic doses.
Okay. And sir, when would you recommend using IV iron, and which is the preparation that is preferred?
Correct. So far we had IV dextran and Jactofos and Interferon, which were toxic when given intramuscularly, and when you give IV, there were rare chance of anaphylaxis and deaths have happened. So we were not comfortable using those. Now we have very safe IV iron like IV sucrose, IV polymaltose. And some of them can be even given as total dose. So that's the advantage now. Carboxymaltose you can give total dose even in a child today. Now there are studies. So IV iron is to be used only for number one, true intolerance to oral iron. When you say that, the child just does not complete schedule, parents don't complete schedule, severe side effect, then you can think of that. Second is in a functional iron deficiency, like chronic renal failure, patient of prematurity, where iron cannot be absorbed easily, even at the rate when you give, because the demand is so high, especially if they're on erythropoietin. So you need to give IV iron. The third is malabsorption. So you have celiac disease till the time celiac is controlled, there's no absorption. You have short bowel, you have some chronic diarrhea because of Crohn's, etc. There it won't affect. And the fourth group is where there is chronic inflammation. So like a rheumatoid arthritis, JRA, malignancy, etc. It's like plenty of iron. If you do the ferritins are high, 2000, 3000. Yet the iron is trapped in the hemosiderin in the storage site, and little iron is available at the bone marrow site. So that's where you can overcome this by giving IV iron, so that a lot of iron at that same time can go to the bone marrow site and lead to production of hemoglobin. And the last indication, not in pediatric, is where you want rapid iron, rapid hemoglobin rise, like in pregnancy. I want to avoid transfusion, then you can give IV iron. So these are only 4 or 5 indications, but none of them are really very largely applicable to children, because most of the children, it is nutritional deficiency. You can treat them with oral iron. And if you are using IV sucrose iron, the dose cannot be more than 4 mg per kg per dose every week. Okay, suppose 10 kilo child, hemoglobin is 6, you want to make it 12, so difference is 6. So 6 into 20 is 60, into 4 is 240, so 250 milligram of elemental iron. So 10 kilo child can receive only 40, so you have to give 6 injections fractionated. Now that's boring for parents. So you have carboxymaltose, which is you can use total dose over 1 hour in an OPD basis under supervision.
Okay. Sir, a question is that according to national initiative, the dose is just 40 to 50 milligrams weekly in children more than 5 years. The doubt is that does that really benefit?
So remember, this is prophylactic and not therapeutic. The prophylactic dose is usually 1 to 2 milligram per kilogram. So iron plus initiative, the NIP has said that 6 months onward you start iron prophylaxis in every baby. So till 5 years, it is 20 milligram of elemental iron. So because to make it simpler for the healthcare worker who is not a doctor in the periphery, they have made it simple at 20 milligrams. So 6 to 60 months, 20 milligram. In your practice, you can give 1 mg per kg or 2 mg per kg. 5 to 10 years, it become 45 milligram. 10 to 19 years, it become 100 milligram. Pregnant and lactating mothers, it become 100 milligram. And women of reproductive age of again 100 milligram. And this is always associated with folic acid of either 100 or 500 microgram. And in baby up to 5 years, you give bi-weekly, and thereafter you give once a week. Pregnant ladies, of course, you give every day till the time of delivery. So that's the NIPI program. And that's enough, because see, what is the requirement? Adult needs 10 milligram of elemental iron per day. Okay. So why should a child receive more than that?
So, sir, should we start iron drops in a newborn who is born to a mother with a hemoglobin less than 10, like right from birth?
So far it was thought that the baby is an obligate, parasite. So it would suck iron even when the mother is iron deficient. But now we know that's not true. That if you have iron deficient mother, that the placenta are small, the babies are small, and they are born with less ferritin in their cord blood, less ferritin in the body. So they will become anemic very fast. So such babies, yes, you can start iron as early as 3 to 4 months. Okay. Remember, in preterms, now what is this magic of 4 to 6 months? Iron given transplacentally remains in the baby enough till he doubles the birth weight. So normal baby doubles the birth weight between 5 to 6 months. So you start iron at 4 to 6 months. A preterm may double the birth weight in 1 to 1.5 months when they catch up. So you start iron at the time of discharge in a preterm baby.
Okay. Sir, if a child has got anemia and iron
deficiency. Now you can keep your video on. I think it's okay. You are very stable now.
If a child has anemia with iron deficiency and also has constipation, which is a preferred iron preparation,
Treat the constipation. The commonest cause of constipation and iron deficiency is bottle feeding or prolonged breastfeeding beyond 18 to 24 months. Both are hazardous. Treat that, improve the diet content, and I think everything will be okay. So really, there's no need to have a specific preparation of iron. Unless there is constipation because of iron, in which case you can start with once a week, then make it twice a week, then make it alternate day, and then make it daily.
Okay, sir. Sir, is retic count routinely important to monitor when you are putting a child on iron treatment?
I don't do it because it's spending the money. I mean, parents, it's really not correct to make them spend for another CBC after 1 week. Besides the prick to the poor child, I do it straight after 1 month. And that time, there's doing retic has no meaning.
Okay. So there's a question that says that in a nutshell, can you explain iron deficiency anemia with iron resistance, IRIDA?
Oh, IRIDA is a genetic disorder where there is a mutation in the compound which does not allow iron to be absorbed. So there is plenty of iron in the body, but the iron is not available for hematopoiesis. And you can only overcome this by giving IV iron. So it's a very specific product where you have iron deficient like picture, but the patient does not respond to oral iron at all.
So, sir, Dr. Bhavdekar is asking, is iron studies required before starting iron in a child with thalassemia minor?
So in a thalassemia minor, you will not give iron because over the time they are going to become iron overloaded because there is increased absorption of iron even in a thalassemia minor. But we have thalassemia minor children coming with 5 gram hemoglobin. Obviously, iron deficiency is overwhelming in such children. So in that case, you will do a ferritin. The ferritin you show that the ferritin is low. You give them only 3 months of oral iron and then stop it. Otherwise, in a normal child, between 1 to 5 years, which is the typical age for iron deficiency, and there's enough reason for him to be iron deficiency for what like bottle feeding, etc. I never do iron studies and never do serum iron TIBC and transference saturation in children because it's very dependent on the diet. Child really cannot be empty stomach, so it's a waste of money. If you want to do ferritin. When you do ferritin, remember not to do when the child is sick or having fever. The ferritin will be an acute phase reactant and will be higher than what you expect. And then you will be misled that it is not iron deficiency.
Okay.
In fact, all the iron deficiency trial that we do, we always do a CRP and show that the CRP is normal. Then that ferritin which is there in the child is actually representing the quiet state of the child and what is the storage in the body.
So, sir, what would be the findings on iron studies in a child who has IRIDA?
Serum iron will be high, and yet patient is not responding to, and he's behaving like iron deficiency. And the diagnosis is by doing straight whole exome sequencing. Don't waste your time in doing other studies. There are other mutation studies besides IRIDA, like hepcidin pathways or ferroportin pathways or transport mechanism pathways or at the intestinal enzyme at the intestinal surface enzyme pathways. All these cannot be diagnosed by your iron studies and clinical. You suspect that a patient is not responding to iron as you want, then either your iron deficiency diagnosis is wrong. If it is proven on the smear, then you would do genetic analysis to see which of these 5 mutation is the cause of iron deficiency, like picture in the child.
Okay. Sir, in most
and remember, many of them will have history of consanguinity. So child with iron deficiency, consanguinity, 2 children having similar problem, not responding, should raise this tentacle that you're dealing with some congenital cause of in the iron metabolism. Jagruti is again, internet is down.
Yeah. Sir,
So Nitin,
Yeah.
there's a question. How does iron help in children with breath holding spells?
Absolutely. So when there's iron deficiency, it leads to so remember, iron is not only hemoglobin, iron is myoglobin. So they have fatigue. Iron is also required in certain enzymes in the brain, especially developing brain. So a lot of like serotonin, dopamine, and other pathways are involved in iron deficiency. That leads to irritability in the child, crankiness, stubbornness, and breath holding. So when you give iron, you replenish this enzyme in the metabolic pathways in the brain, and the patient's breath holding becomes normal. Yeah, Jagruti.
Yeah, sir. Sir, so like a lot of our patients could also be having a dimorphic anemia because they could also
Correct.
be B12 deficiency as well. So does
Correct.
the MCV kind of normalize because of both it being there? And if so, what are the clues to picking them up?
So when you have a child with nutritional reason to have anemia, your hemoglobin is low, but your MCV is not as low, but your RDW is very high. So now that tells you that there is dimorphic picture, because micro macro will lead to a lot of high RDW, but they will cancel each other for the MCV. And the typical diagnosis on the smear, you see severely hypo micro picture on one side and a macro picture on the other side.
Okay. Sir, and what is the role of iron in pica and for how long should we give it?
So
And
again,
should we give them
pica like breath holding, once you have ruled out the neurological conditions like a child with cerebral palsy or some parietal insult, etc., which can also lead to this type of behavioral problem, then it is again the same altered enzymes in the brain which leads to this altered appetite, and you give them iron and the pica disappears. Pica can be also the cause of iron deficiency because if they eat mud, geophagy as we call, it traps whatever little iron is there in the diet. So it further accentuates the iron deficiency. It's a vicious cycle.
So is that the same for using iron in children with breath holding cyanotic spells?
Absolutely. Breath holding acyanotic spells are cardiac in origin generally.
Right.
Breath holding cyanotic spells are iron deficiency or neurological condition in general.
Okay. So, sir, there's a question by Dr. Gayatri. In an ITS patient, after starting vitamin B12, I think we are moving on from iron deficiency.
Yes.
So,
Yes.
after starting injection vitamin B12, sometimes tremors increase during
Absolutely.
the treatment course itself. What is
Correct.
the reason for that? And should we continue the same or anything else should be ruled out?
Correct. So, infantile tremor syndrome, which is typical of a megaloblastic anemia in a very small baby, usually it is because of the also megaloblastic picture in the mother, and the child is on exclusive breastfeed, so it doesn't get any B12 from outside, and they have the infantile tremor syndrome. And remember, infantile tremor syndrome with megaloblastic anemia, you treat them with B12 folate and of course iron also. The megaloblastic anemia will improve and disappear, but the infantile tremors may or may not completely disappear. And there is also like a therapeutic paradox in after starting AKT in some patient. There is similar therapeutic paradox after starting B12, but it is no reason for you to stop. You continue a B12. In fact, you give injectable. This is the only reason where, I mean, only place where I use injectable B12 to start with in a baby. Otherwise, in an older child with megaloblastic anemia, you give oral B12 and folic acid. There's no need to give injectable. We see a lot of people giving injectable Bitcofol and things like that. It is not required. That's a typical schedule for pernicious anemia, which is not the reason for megaloblastic anemia in children. They are all nutritional. Unless they have diarrhea, then they will not absorb when you give oral. So you give injectable to start with. But generally, 9 out of 10 times, you can do away with by giving them good dose of oral B12 and folate. And remember, when you're not doing B12 folate level and you don't know what the cause is, you always give B12 and folate together. If you give only folate, the megaloblastic anemia will improve, but the neurological signs of B12 deficiency will deteriorate, and that may be permanent. So always give B12 and folate together.
Sir, should we in that case what is the role of doing B12 levels or folic acid levels or homocysteine levels in such patients?
Correct. So if you ask me very frankly, if I have a child of megaloblastic anemia, what is that? Either a very small infant or a adolescent boy or girl. Generally, usually 3-4-year-old children don't have megaloblastic anemia. They have typical iron deficiency. I don't do B12 folate. I put them like iron therapeutic test. I put them on B12 folate and I follow them over a month or two. If everything becomes normal, then it does really not matter. But if suppose they are not in the typical age or if they're not responding, then you can do. Remember, doing B12 and folic acid is few thousands of rupees. And doing only B12 without homocysteine is like a barber without knife. B12 can be normal in a general population up to 10%. I mean, low up to 10%. And B10 can be normal in some people with megaloblastic anemia. So how it helps you? Unless you have B12 of 80, 100, it really doesn't cleanse the diagnosis. So that's the reason why if you want to do B12, you should do with homocysteine and methionine. If both are high, then you know that you are having B12 deficiency. If they are not, then it's not. It's just a normal what you call normal change in the B12 levels in the community. So never do B12 alone. I don't do B12 folate, if you ask me very frankly. I just put them on. So I do smear. I see macrocytes. I see polychromasia. I see some such picture like Abbott ring or whatever else. Then I put them on B12 folate and follow them. If another 1 or 2 months, if they don't improve, then I do a bone marrow. And then I may do something else because I might have missed a hypoplastic anemia, which may also look like a megaloblastic anemia, or a myelodysplastic syndrome, which may also look like a megaloblastic anemia. But I'm telling you, 99 out of 100 times, I will not have to do a marrow. I will not have to do B12 folate level.
Okay.
Now there's one more test available as holo B12. That's an active B12. So instead of doing total B12, do active B12. You know, when you take B12, B12 is with either transcobalamin or with the liver type of what's that known as hepatocorrin. So if you have the active part is the one which is attached to the transcobalamin. That's known as holo. So if you do holo B12, that's an active part. That is low. It will tell you even much more than doing a total B12. But that's again expensive, 2,500 plus.
So there's a question that says that knuckle pigmentation is what we commonly see with children with B12 deficiency.
Correct.
One is, what are the other causes for these kind of pigmentation? Two is whether we should do B12 levels in such patients. If it is low, how low is actually low? How long do we treat and how long does it take the knuckle pigmentation to reverse?
So knuckle hyperpigmentation with anemia, which is macrocytic, with high RDW. Mark my 4 words. Anemia, macrocytic, high RDW, and hyperpigmentation is typical of megaloblastic anemia. Without anemia, you just have hyperpigmentation. It may be familial, it may be the color of the child, etc. Or there may be subtle B12 deficiency. There's no harm in giving them a B12 trial, but I'm telling you, most of the time it will not help. But in a setup of megaloblastic anemia and hyperpigmented knuckle, the problem is because of melanin hyperproduction in those areas of friction, which are the knuckles. So you give them B12 everything, and that stimulus goes, and the color changes in next 2 or 3 months. So it takes time.
Okay.
But if you have a hyperpigmented knuckle, besides that, is not the typical knuckles, but also the entire hand and some also on the face, etc. Never forget to rule out Addison's disease. We have had seen children where people have made mistake of megaloblastic anemia and they actually turned out to be Addison's.
Right, sir. So Dr. Saurabh is asking, what is the schedule of IM vitamin B12 in nutritional megaloblastic anemia with a developmental lag? Are there any proper guidelines available for the same?
Correct. So if you have a nutrition anemia with developmental lag, means you are talking about infantile tremor syndrome like in an infant. In such case, yes, giving initially injectable for say a few weeks. So normally you give in a small baby, malnourished baby, never start with 100, 500 microgram, because you know what is megaloblastic anemia? It's a nuclear cytoplasmic asynchrony, which means cytoplasm is all ready to divide. So it's a large cell, but the nucleus cannot divide because the B12 is not there, which is a cofactor for making of the nuclear proteins. So moment you give B12, the nucleus will rapidly divide. Cells will become 1 to 2, 2 to 4, 4 to 8 very rapidly. And when the cells divide, they will imbibe potassium. So if you have a patient who is malnourished and you give too much of B12, you may lead to hypokalemia, which can be fatal. So in a small baby, you start with 10, 20 microgram for the first few days and then make it 50, 100 and then gradually go up. But in an older child, there's no harm. You can start with 100 to 500 microgram, give once a week for 3 to 4 weeks, and after that, make it oral as early as possible whenever the child is able to take and the diarrhea has disappeared. In only pernicious anemia, you give 500 microgram, 1000 microgram once a week, then you give once a month, and then you continue lifelong. But you rarely see pernicious anemia in children.
So, sir, how do we diagnose pernicious anemia, Dr. Iyer?
Correct. So, pernicious, so see, that's why if you have a child who is adolescent, has megaloblastic anemia, and has associated autoimmune feature like diabetes, leukoderma, alopecia, joint issues, then you know this is some autoimmune phenomenon in the child. So you could also have autoimmune megaloblastic anemia, which is pernicious anemia. In such children, you will do the antibody against the islet cell, I mean the intrinsic factor and the gastric parietal cell, but otherwise we don't. Or your megaloblastic anemia, you are given oral B12 folate enough dose and for long time, and yet the hemoglobin is not improving, then again you think that this is a pernicious anemia.
Okay. I think, sir, you have sorted quite a few doubts regarding megaloblastic anemia. So I will move on to ITP, and I'm going to give you a rapid fire on that, sir.
Sure. Okay.
So, sir, do we admit all freshly diagnosed cases of ITP?
I never admit a single ITP child unless he's having significant mucosal bleed. And if people who are working in Hinduya with me can vouch for it, that I take them to the procedure room early morning on empty stomach, do the marrow, 2 hours, observe them, and send them home. Evening, they are at my clinic. I read my own marrows. I give them the report, start them on oral steroid when the marrow is normal. And in 100, 200 rupees of steroid, the treatment is over. And the bone marrow, even in a setup like Hinduja, it will not cost more than 12 to 13,000.
So, but marrow is a must. That means
marrow is not a must unless one, you are not sure, you have not seen the CBC yourself, the smear yourself, and we have enough number of time when a so-called ITP turns out to be malignancy. Number two, abnormal counts, like you have low hemoglobin with an ITP, you have little low or high WBC with ITP, borderline low neutrophil with ITP. Third, if you are going to start steroid, no matter what, in our country, you must do bone marrow because people might have pre-treated him with steroid and everything is a disturbed picture of leukemia and you will have trouble. We see at least 2 patients every year in Vadia, which are labeled as ITP, treated with steroid without a marrow. They come after 1 or 3 months with full-blown relapse leukemia. So I suggest that before steroid, we must always do.
Okay.
If I give you IVIG, okay, you need not do.
So first episode you would treat with oral steroids as far as possible.
Oral steroid only. US was the only country which was preferring IVIG over steroids. UK always says steroids because it's easy to give. Now that IVIG is in short supply because there are no donors to give your plasma, IVIG is going to be difficult to get. So even US is moving more towards steroids.
And even for subsequent episodes, would you treat similar?
Anytime. If someone was steroid responsive in past, I would start still steroid short courses. So let me tell you, I give 4 mg per kg of prednisolone for the first 4 days. That's high dose. So I have a 40-kilo child. He will take 160 milligram of oral prednisolone for the 4 days. Then make it 2 mg per kg for the next 4 days. And then you judge the response at the end of 4 days and 8 days. If the response is massive, you can stop there and then. Otherwise, taper quickly over the next 1 week and then stop it. And then subsequently, if they have a bleeding and the platelets are low, you can just give them 4-5 days, 1 week steroid like how you give in asthma. That's enough to tide over the crisis.
Okay.
You know, the adulterated opinions, a lot of people go to the adult hematology site. The adulterated opinion, they keep, like, adults have chronic ITP. They are on steroid for months and years together. So my job many times when I get second or the third opinion is to reduce the number of doses. And I'll tell you, I mean, I don't have the prescription to show you now, but there's one child of IT who came to me, he was on 7 drugs. He was on oral steroid, then he was given dexamethasone, he was given IVIG, he was given rituximab, he was on dapsone, he was on L-trombopac, and he was on cyclosporin, and someone had started him on cyclophosphamide. I mean, you don't do this in children. And I asked, when did she bleed last from the nose? She said she has never bled from the nose. I said, then what are you treating, the platelet count or the child? There's not a platelet count. Every time the child's platelet falls, she's in ICU, given platelets, all rubbish. All I do is remove one after the other drug, and believe me, in the 1 year's time, that girl's platelet became 40, 50,000, enough not never to lead to bleed. And after 3 years, has a platelet now more than 1 lakh. So one message I want to give you: one, never give platelet transfusion in an ITP. Two, don't worry about treating the platelet count, treat the patient. When you treat is only when they have wet bleeds, which will have significant epistaxis, GI hemorrhage, etc. First time you may give steroids because you want to see the steroid responsiveness and the parents are very anxious the first time. But subsequently they get used to low platelet and you need not restart steroid again and again.
Sir, what is the treatment of ITP in young infants like 6 to 12 months?
First of all, ITP I've seen as young as 4 months, but that's rare. Generally, if you have played ITP less than 6 months, you should double check on the diagnosis. And how you do is, one is immature platelet fraction. It should be high. Number two, marrow. Marrow should show you normal marrow with probably increased megakaryocyte. That's the way you diagnose. Once you have ITP diagnosed in a small child, if it's 4 or 5 months, there is no harm. You can give him steroids.
But, sir, what is the risk of intracranial bleeding in a child with ITP?
So let me tell you, when is the risk of intracranial bleed? A study done on consecutive 100 patients of intracranial bleed, they found that in ITP, the intracranial bleed can happen on day 1 to day 100 and on a platelet count of 1,000 to 40,000. So there is nothing like a safe platelet count and a safe period where you say now intracranial bleed will not happen. And 80% of those who intracranial bleed either had fall and injury or had been given NSAIDs, Meftal, Meftal P, ibuprofen, ibugesic, plus all aspirin, dispirin, anacin, big no, only paracetamol. If the child has no injury and is not given NSAID, then he will not have intracranial bleed. So the fear of intracranial bleed and I can be sued, so I will treat every time very vigorously, I think is completely not correct.
Right, sir. Okay. Sir, yeah. Sir, there is a question on, is there a role of rituximab for patients who come with recurrent ITP, or is it only reserved for chronic ITP?
Correct. So rituximab is a treatment of patient with ITP who is having significant wet bleeding in the form of epistaxis, GI hemorrhage, hematuria, or menorrhagia in an older child, and you have exhausted steroid, IVIG, cyclosporine, etc., then is the role of rituximab. Remember, rituximab in ITP works good, but it can lead to profound immunodeficiency, which can last for a year, 2, or even up to 5 years. So it's not a drug that you should play with, and there are specific indications where will you use rituximab. It's known as medical splenectomy, but under an expert guidance and for a very specific indication.
Sir, adult hematologists have also started using L-Trombopag in their patients.
Yes.
So what is the role in children?
Correct. So what is L-Trombopag? L-Trombopag is a thrombomimetic agent. So it induces thrombopoiesis. So when you give that, the platelet count goes up and the bleeding will stop. But moment you stop the drug, the platelet count will fall again. So it is only to tide over the crisis. So suppose there is a adolescent girl with menorrhagia, you are given steroid, she's not responsive. Now 80-kilo child cannot afford IVIG every now and then. You have tried Dapsone, it's not working. What is your choice now? Now your choice is either do undersplenectomy or rituximab or cyclosporine or that time L-Trombopag. But you only tide over the crisis for few months. Adults, because they are chronic ITP always, they use a lot of L-Trombopag. Remember, it's an expensive drug and it's not going to cure the ITP. In fact, none of the drugs cure ITP. They only help you to tide over the crisis. So if you can then tide over the crisis with some other simple measures, it is easier to do that than to give L-Trombopag. I very rarely use L-Trombopag. L-Trombopag is very fashionable with even some teaching institute I won't name, but I am telling you, it's not a wonder drug. It's a wonder drug for hypoplastic anemia or aplastic anemia. And we have a series of 16 children with aplastic anemia who would have otherwise undergone bone marrow transplant, but we have put them a cyclosporine L-Trombopag, and almost 14 out of 16 responded and they are transfusion free and their counts are almost near normal for at least 2 to 3 years. That's the indication of giving L-Trombopag. And remember, now we have Indian brands generic of L-Trombopag which are legally available and they are quite cheaper than the international brands.
Sir, in a patient with suspected ITP or recurrent ITP or maybe even chronic, when do you suspect autoimmune causes like APLA or SLE?
So adolescent girl who has beyond ITP, either low hemoglobin and Acumis positivity, you do a urine protein creatinine ratio, it is a little higher than normal, or she has got associated conditions like thyroiditis, hypothyroidism, alopecia, joint pain, etc. Is the time when you think that ITP is not ITP, but it's a ITP plus. So it can be ITP plus autoimmune hemolytic anemia, what you call Evans syndrome, or it can be ITP plus autoimmune hemolytic anemia plus neutropenia, what you call Evans plus syndrome. And many of these Evans plus can be immunodeficiency syndrome. They could be part of ALP syndrome and so many other things. And of course, adolescent girl, you do an ANA, it comes positive. So normally we don't do ANA in children with ITP, but adolescent girl who is chronic ITP, at least 6 months or 1 year since the onset, at least once you should do an ANA.
So right now we spoke about platelets, like transfusion. So can you keep platelet in your fridge for an emergency use? Is a question.
My God. Platelets are stored at 22 degrees temperature and fridge temperature is 2 to 4 degree or 2 to 8 degrees. So never keep platelet in the refrigerator. If you have kept it, you have to throw that pack away. It's a useless platelet. So never, it has to be kept at room temperature, and it's kept on a constant agitator because platelets have a tendency to clump together. So they have to be everted. So there is a platelet agitator which keeps on moving like this, and that's how you keep the platelets. So you cannot keep the platelets in your refrigerator.
And sir, in case of patients with hemophilia,
in fact, Jagruti, when suppose you don't have a blood bank and you're asking the patient to bring platelet from outside, you have to tell the parent that they have to every minute or so they have to keep on inverting the bag. Unless,
yes,
of course, they are traveling in a rickshaw in Mumbai, then that is not required.
yeah, then it's an agitator itself.
Then the whole body is agitating along with the platelets.
Right, sir. So Dr. Iyer is also asking for the indications of splenectomy in a patient with chronic ITP. TPO agonist you have already spoken about.
Correct. So now with the advent of cyclosporin, rituximab, and eltrombopag, splenectomy is rarely done now. I don't even remember last when I have asked for. But in an adolescent girl of ITP, nothing is helping. Then there's the chance where you do splenectomy because the menorrhagia is really troublesome with these girls.
Okay.
Or an emergency splenectomy. Suppose an ITP has come with massive interaction and bleed. Okay, now how you will save his platelet count has to jump. Your eltrombopag will take 3-4 weeks for the platelet to go up. Rituximab will take 2 weeks for the platelet to go up. So you give that patient double the amount of platelet then for his body weight under cover of IVIG and methylprednisolone. Other surgeon immediately open up, clamp the splenic vein, and the platelet will start rising and then do the splenectomy. So that's the only indication really in today's time. A child who is really massively bleeding.
So there are two questions related to platelet transfusion. One is single versus random donor platelet transfusion.
Correct. So
and
RDP versus SDP. Yes.
Yes, sir. And two is how much platelet count would increase is expected with 1 unit of platelets and in how much time?
Correct. So remember, an SDP or a single donor platelet is number of platelet taken from one donor. So if the patient is attached to a cytophoresis machine, his blood is taken out, only the platelets are taken out from that and the rest of the blood is given back to him. And like that, these cycles continue. So you take almost 6 to 7 bags of random donor platelet from that one single donor. So random donor platelet is not more concentrated. It is more in volume. So typically a random donor platelet is 50 to 60 ml. When you do an SDP from a donor, you take it around 250 to 300 ml of platelets. So advantage is that a big boy would need 5 bags of platelet. He can need only one SDP because it has already 6 or 7 bags of platelet worth. So you limit number of exposure donor. This is important in patients who are transplant in a malignancy, etc. Okay. So you have designated 2 or 3 donors and the donor can again donate after 2 weeks. So you have 2 donors who are tandem donates for one patient and you don't expose them too many and jeopardize your transplant survival. Otherwise, single donor platelet, random donor platelet, the number of platelet per ml is the same. Now you use SDP in a bigger child and a child who is needing recurrent transfusion. You use RDP in a smaller child who is not going to need recurrent platelet transfusion. The dose is 10 mg per kg or 1 bag of random donor platelet for 5 to 10 kg body weight. And that would raise the platelet count by 30 to 50,000.
And sir, how long will that effect last or will it?
So the life of a normal platelet is 5 to 7 days. That of a transfused platelet is 3 to 5 days. So by third day, your platelet count will be almost back to normal. It can be back to normal even in 24 hours if there is consumption coagulopathy, like in infection or DIC. So just one practical tip I'll give to the listener that suppose you don't know the cause of your low platelet, okay? And the child has come with epistaxis. Now you have to give him platelet till the time you find out. When you do that, do two things. You do a baseline platelet, say it's 10,000, okay? You give him, say 10 kilo child, you gave him 2 bags of random donor platelet. You do platelet count at 1 hour and 24 hours. At 1 hour, the platelets jump to 30-40,000, which means there is good recovery. It is not immune cause of thrombocytopenia because in immune cause like ITP, no matter how much platelet you give, within 5 minutes they are destroyed. Now 1 hour platelet is 30-40,000, but at 24 hours it is still 20-30,000, which means there is good recovery even at 24 hours. That is a chronic thrombocytopenia because of decreased production like aplastic anemia, malignancy, etc. But if your 1 hour was okay, but 24 hours is back to 10,000, which means all you gave is consumed in next 24 hours, it's typical of DIC, thrombosis, or sepsis. So you can find out the cause of your low platelet by doing this experiment.
Right, sir. So Dr. Kadam is asking that I have a patient 6-year-old male child with history of fever for 20 days with pain in abdomen with palpable purpura over bilateral lower limbs. The
Correct.
CECT abdomen is suggestive of cholelithiasis with acute cholecystitis and empyema of the gallbladder. However, the platelet count is always normal. How to explain this?
So probably the rash is not because of the low platelet, but basis some vasculitis. So henoch-Schönlein purpura can come this way. It may not be purpura at all. It may be actually erythema nodosome-like picture, which looks like a palpable purpura, especially in the sheen of tibia in small children, and that may be seen in many chronic inflammatory conditions, including tuberculosis. And if he has empyema of the gallbladder, then primary problem is fever with abdominal pain there. You treat that, and the secondary vasculitis or whatever else is the reason for the rash will probably disappear.
Okay. Sir, can you discuss about any newer modalities of treatment which are available now for hemophilia, both A and B?
Oh, okay. So, hemophilia A, there is a nice monoclonal antibody available. So, for that, you need to understand how factor 8 works. So, factor 8 is a bridge between activated factor 9 and factor 10. So, factor 12 leads to activation of 11, 11 leads to activation of 9, 9 activated factor in presence of 8 leads to activation of factor 10, and then factor 10 leads to further cascade till thrombin is produced and fibrinogen is converted into fibrin threads. Now, when factor 8 is missing, 9A cannot activate factor 10, and that's where the block is in the hemostasis and the patient bleeds. So there is a bivalent monoclonal antibody. It is available. It is known as emicizumab, available as Hemlibra, and that attaches to the activated factor 9 and factor 10 simultaneously. So it replaces the function of factor 8. So that's a great advantage of using. I mean, you can use it's a subcutaneous injection. The parents can give it at home, and there are schedules which I will not, of course, say here, but suffice to say, the studies done in hemophilia have shown that the amount of factor 8 needed or the bleeding episodes are reduced by 95 to 98%. So it's almost like a sort of cure, but they have to take it for lifelong. So that's for factor 8. Both for factor 8 and factor 9, a lot of people have worked on the gene therapy. So for factor 8, it's a big gene, so it can't enter a vector like adenovirus vector. So you have to reduce the factor 8 gene by removing beta domain, as we call, and only the active factor 8 gene is introduced through this adenovirus like vector. And for factor 9, you take a what you call as naturally occurring PODA variant of factor 9 gene, and again use the adenovirus based vector, and you inject it into the patient. And studies have shown that of course, this gene therapy is only allowed in above 18 years adults, and those without inhibitors to either factor or factor 9, depending upon which condition. And they have shown to again reduce the need for factor and bleeding episodes by 80 to 85%. So very promising. Factor 8, of course, is very promising. Someone can afford 5 to 10 lakh rupees a year, can actually do away with factor replacement and go to the Hemlibra.
That
and
is
it's available in
amazing,
India.
sir, to know. It's really
Yes.
amazing to know. So these
Yes.
subcutaneous injections can be given by the parent also, no?
Yeah, it's like insulin. So initially it's weekly for 4 weeks. After that is once a month.
Okay.
The cost is the problem. Dose is not a problem.
Right, sir.
And
So-
I'm sure some manufacturer from China or somewhere else will make a generic version, and after the expiry of the the patent, the generic will be 1/10 the cost, and the same story will repeat.
So that's really interesting. Sir, doctor, there's a question that is there any indication of whole blood transfusion in today's era? Or
Okay,
have
so
we done away with?
no, so first of all blood banks should have component made. Any blood bank which doesn't make component should actually not have license, because from one bottle of blood you can make one packed cell, one fresh plasma, and one platelet at least. Okay, and the fresh plasma can be pooled to make further albumin, IVIG, and so many other things. So it's criminal to give whole blood to someone who just needs, say, oxygen carrying capacity, like an anemic child or a bleeding child, where a packed red blood cell will do enough. So only indication of whole blood cell today is exchange transfusion in small newborns, and in massive transfusion, where there is more than one volume blood exchange lost in say 12 to 24 hours, or there is more than 3 ml per kg per minute of blood loss. then that child needs all the three components. And similar type of blood loss will be there in ECMO or in severe cardiac surgeries. In such case also, you need not have a whole blood in your fridge. You can give Paxil, FFP, and platelet in 1:1:1 ratio and still do the same work as whole blood.
Right, sir. Sir, in hemorrhagic disease of the newborn, I mean, usually we aren't seeing too many of those cases, but in case we do come across something like that, if somebody has been given vitamin K at birth, does that always rule out the possibility of getting hemorrhagic disease? As in, is there a possibility of failure of the vitamin K that we so routinely give at birth? Is there a role of what we learned as PIVCAS to monitor in such patients? And whether we treat it with FFP or like, do we just give a large dose of vitamin K?
Correct. So 1 milligram vitamin K given at birth prevents hemorrhagic disease of newborn to the tune of 99%. But sometimes there may be mistake in calculating dose, or the dose has gone subacute or is not given properly. In a preterm child, again, it may not be just the vitamin K, but also the liver immaturity, which also leads to bleeding. So such children can, even in spite of vitamin K, come with problem of bleeding as a hemorrhagic disease of newborn. So such cases, you give vitamin K generally if they are not actively bleeding when they come to you. So typically, how does it present? They present with either small GI hemorrhage, or they have these cutaneous nodules, which are nothing else but hemorrhage, what you call blueberry muffins. Okay, and then you do PT-PTK. Your PTK is your PT is grossly prolonged, and it's vitamin K deficiency. Now they are not bleeding actively. You can just observe them, give them vitamin K, and in 12 to 18 hours, the PTK become normal and the bleeding will stop. But if they are having significant mucosal bleed, like GI hemorrhage, massive intracranial hemorrhage, then you also have to give FFP. And in a preterm, always give FFP, because you're never sure whether vitamin K alone will work or not. You talk about PIVCA. What is PIVCA? PIVCA is protein induced in vitamin K absence. So suppose you had a child, say, transferred to you with history that this child had, say, 25 days old child was brought with GI hemorrhage, and someone gave him vitamin K and transferred to you after the next day. Now you do PT-PTK, both are normal. Now you don't know they are normal because they were normal to start with, or they were abnormal, but the vitamin K which was given has made it normal. So there's no way to now prove that they had abnormal PT to say that that was vitamin K deficiency. And their parents want to know, is it that or hemophilia? So what do you do in such cases? You do PIVCA. Because if there was vitamin K absence, the protein induced in vitamin K absence will remain for at least few days to a week. So it will help you establish diagnosis. By the way, it has no therapeutic role.
Right. So nowadays,
and as far as hemophilia is concerned, if someone is given FFP, then your PTT can get little corrected. Then you will not know. So you repeat your PTTK after 48 to 72 hours. The half-life of factor 8 is 8 to 12 hours. Half-life of factor 9 is 12 to 18 hours. So by 2 days, factor 8 and factor 9 from the FFP which is given would have disappeared. And now you do a PT-PTK, it will be actually the same as that of a child before FFP was given. But for factor 13, you have to wait for a month, because the half-life of factor 13 is 21 days. So if someone is given 1 dose of FFP, and factor 13, comes with either umbilical cord bleeding or intracranial hemorrhage. So you do PT-PTK, you do even factor 13 level, it come normal. So you do after 1 or 2 months a repeat factor 13 level, and you can come to the diagnosis.
Sir, how much of prolonged PTT over the normal is considered as abnormal?
Correct. So in a way, I'm happy that I get a lot of references of surgical patients who have done PT-PTK, and they are little plus minus here and there, and the surgeon says, no, you get an approval from someone. So PT always look at INR. So generally, plus or minus 3 seconds is permissible for PT, but better is INR. All INR should be below 1.2 to 1.3. APTT or PTTK, as we call, is plus minus 10 seconds over control. And the controls are never historical. Many labs write PTTK of the patient 28 into the bracket 20 to 25. There's nothing like into the bracket 20. They have to do in the control at the same time. Okay, so send to lab which are doing control every day. So they will tell you PTTK of the patient is 28 seconds, control is 22, that's normal. PTTK of the patient is 38, control is 28, that is normal. But PTTK of the patient is 50 and control is 25, that's not normal. So that has to be diagnosed for factor 9, factor 8, or factor 11 deficiency.
Right, sir. Sir, in correlation with what we were discussing about vitamin K, we have two preparations of vitamin K. One is a 0.5 ml giving 1 milligram, and one is 1 ml giving 1 ml giving 10 milligrams. So we give 0.1 ml of that. So there could be times when, you know, there can be a dose confusion between the two. And suppose one is not vigilant, or there is an emergency. In which case, if we give a larger dose, like if you end up giving a larger dose of a preparation where you have to give 1 milligram, so if you give 0.5 of that versus somebody who is given only 0.1 of the one where you have to give 0.5. So what can happen, and how do you take care of that?
Overdosing is never a problem. Underdosing in a newborn will be a problem because that baby is as good as not protected. So if you have found out that you have made a mistake in giving 0.1 ml from the 0.5 milligram dose, then you repeat the dose. But if you're given instead of 1 milligram, 5 milligram or something like that to a child, no harm is done.
So can it cause hyperbilirubinemia enough to...
So in a child with hyperbilirubinemia, it can lead to further hyperbilirubinemia. But in a normal child, it is not really an reason for a severe hyperbilirubinemia needing exchange or something like that.
Okay, okay. Fine. And sir, in the newborn screening that we do nowadays for abnormal hemoglobins, can it effectively rule out a thalassemia trait and sickle cell disease completely?
So thalassemia trait, yes, it can rule out because hemoglobin A2 will be normal or high. Thalassemia can never be diagnosed because HbF level is high at birth in many babies. So you'll have to wait for 6 months to show that the HbF is still high. Sickle cell and other hemoglobinopathy like C, E, etc., D, hemoglobin D, they will all be picked up on electrophoresis done on that spot of blood. So except beta thalassemia, major, you can diagnose most of them on the blood taken at the time of birth.
Right.
I mean, I saw one child who was sickle cell anemia and who came with a whole exome sequencing done. I said, what is this? You don't need whole exome sequencing for sickle cell anemia. All you need to do is a sickle cell, electrophoresis and a sickling preparations. So, you know, people misuse this type of picture. If you want to diagnose thalassemia major before 6 months, then you do parent study. Both are thalassemia minor, obligate carriers as we call. You do their mutations and you see whether the child is inheriting both the mutation. That you can do even at birth, but that's not required. You can wait for 6 months unless the parents are very anxious. Then you can do earlier by doing genetic study, but not by electrophoresis.
Okay, sir. Sir, and there can be no CME without asking you questions on vaccinations. So can you briefly tell us about the vaccination protocols for patients who are to be splenectomized and also patients who are having malignancy who are on like chemotherapy?
Okay, so first splenectomy, remember spleen is a major lymphoid organ to make antibodies. So when you remove spleen, post-splenectomy infections are so high and especially invasive sepsis. So you should give vaccination before spleen is removed unless it's an emergency splenectomy or a traumatic splenectomy. Otherwise, you should wait for at least 2 weeks before splenectomy for all the vaccination to be over. Now, in absence of spleen, the commonest sepsis is caused by capsular organism. So they are very prone to pneumococcal infection, but also to meningococcal and to some extent typhoid and influenza. So you would give, and of course Hib, the H influenza type B. So you will give them the age appropriate Hib vaccine, PCV, then you will give them typhoid conjugate, influenza and meningococcal conjugate quadrivalent vaccine. And all this can be given simultaneously as 4 injection, 5 injection, at least 2 weeks before splenectomy. And subsequently, if there is enough time for the splenectomy to happen, you can give him the 23-valent polysaccharide pneumococcal vaccine 8 weeks after the PCV 13. But if suppose there is no time to wait, then splenectomy can happen and you can give the PPSV 23 post-splenectomy. Now, for some reason, vaccines are not given before splenectomy, then you need to start vaccination 2 weeks after the splenectomy. And irrespective whether the child has received PCV or not PCV, penicillin prophylaxis has to be continued for at least 5 years, maybe lifelong. And come to malignancy, no vaccine will work during active multi-agent intense chemotherapy. So that in a leukemic child is typically for the first 8 to 9 months when the protocols are going on. During maintenance, when they are only on oral medication, some vaccine like influenza can be started, but the other vaccine may still not work. So you can even give varicella vaccine that time, but you have to stop the chemotherapy for at least 2 weeks before you give the live vaccine like varicella vaccine. But typically, we start all these vaccines 6 months after the last chemo is over. Last chemo means all oral maintenance chemo is over. 6 months after that, you start from where you left, and the vaccine that the child has received, he may have lost some memory to that. So you may give one additional dose. So that's the way we give vaccination. In a transplant setting, you have to revaccinate completely because that's a naive person. He has lost all his memory because of transplant. So you start all killed vaccine 1 year after transplant when the patient is off any immunosuppressant, and live vaccine 2 years after successful transplant. That in nutshell is the way you go about vaccination.
Okay. Sir, Dr. Kadam is asking that we have recently diagnosed a sickle cell anemia in a 2-month-old baby. Do we have to repeat the electrophoresis again at 6 months of age?
Absolutely not. Unless you are talking about sickle thal, then that's a dip. But if it's homozygous sickle, which means HBS level is more than 70-80%, and the HBF is around 10%, and HbA2 is around 5%, then you know this is homozygous sickle. And you can do parent study. Both the parents are only sickle trait. That means this is sickle cell anemia. No need to repeat. Just put the child on penicillin prophylaxis, give him age-appropriate pneumococcal vaccine, finish all his vaccination, start hydroxyurea at 4 to 6 months. So that you don't allow any crisis to happen. So they will be on folic acid, they'll be on penicillin prophylaxis, and they'll be on hydroxyurea, and that will be lifelong.
So a sign of a good third umpire is to answer queries even before they're asked. So that was the next question that Dr. Madhuri Kadam had asked. So thank you so much for the answer.
So the dose of hydroxyurea is to start with 10 mg per kg per day. You can go up to 30 to 40 mg per day, what you call the maximum tolerated dose or MTD, but do not allow the hemoglobin to rise more than 10.5 because hyperviscosity itself can lead to more sickling. So we use a dose between 10 to 20 per kg per day, especially when our sicklers are not that severe, unlike African sicklers. So you can do with 10, 15, 20 mg per kg per day and have a reasonable hemoglobin level of around 9 to 10, and that's enough to prevent most of the bone and other crises.
Sir, Dr. Palani Raman is asking, what is the current management of hereditary spherocytosis?
So current management of hereditary spherocytosis, put them on folic acid because they can go into secondary megaloblastic anemia. Watch for the hemoglobin level. Transfuse them when the hemoglobin drops to below 6 or so, and or if they have severe growth failure. Otherwise, don't transfuse. And if they are needing transfusion again and again, or they are not transfused but the growth is not that great, then when they become 5 to 6 years, you can undertake splenectomy. But if someone who is mild variety, who is growing well, is not needing transfusion, is doing well only on folic acid, there is no need to do splenectomy no matter what the spleen size is. Unless the spleen size is so big that now it leads to secondary hypersplenism, which means your ANC is dropping, your platelets are dropping, then you may have to remove spleen from that point of view, but not because of the spherocytosis. And when you do splenectomy, before that, always do ultrasound. And of course, you do ultrasound every year to see for gallstone because these children are very prone to gallstone. So if there are gallstone, then the same sitting, do splenectomy and cholecystectomy so that you avoid another major surgery in a small child. And you can do nowadays splenectomy as well as cholecystectomy through laparoscopic surgery, even in a small child like 6-7 years, very successfully.
Yes, sir. Sir, should thiol traits be supplemented with folic acid?
So I prefer to see, depends on the diet. If the diet is really good, that is not required. But otherwise, you can tell them that you take 1 tablet of folic acid every Sunday. So that's the way to remember.
Right, sir. Okay, sir, I think we have almost reached all and answered all the questions. And today, after this massive marathon of questioning that I have had with you, I now understand what they mean by Gagar mein Sagar Samana. Actually, the entire plethora of questions, and it's like a revision of the entire Hemat Oncology with you. And though we have covered more of Hemat because as practicing pediatricians, yes, that is what we come in contact with. So I think, sir, thank you so much for doing such an excellent job and answering all our queries. We are really, really grateful to you. Over to
Thank
Dr.
you,
Chokhani.
Jagriti. Jagriti, you were a master moderator and a master class master, and I thank the IIP Mumbai for giving this opportunity, especially Dr. Rajesh, who is my colleague at Hinduja, is here. Thank you very much for this wonderful session and giving me this opportunity. And I reiterate what you said at the beginning. I reiterate what you said, Rajesh, in the beginning, that this is a voting time. Everyone must vote. If someone doesn't vote, it's not a good thing for the self as well as for the IIP. It's both your right and duty. So please exercise vote. Whosoever you want to vote, doesn't matter, but please do vote.
Yeah, I think so. So actually, if you just post in the groups or here that you have voted, it gives all the IIP Mumbai people a lot of encouragement to keep bringing many more good activities for all of you. And for Nitin Bhai, I will just say at one of the schools, they asked them to spell power bank and they spelled it as NITINSHAH. So that's Nitin Bhai for all of you.
Thank you so much.
So thank you, Nitin Bhai. And thank you everyone for logging in. We have the next series of this Webflix series on Friday evening, 9:30 p.m. Today there was some confusion about the time. I am really sorry for that. So Friday evening is 9:30 p.m. and our third umpire is none other than Dr. Vrajesh Udani. So let's have a good amount of learning in neurology from Dr. Udani. Thank you everyone once again for joining in. See you all again on Friday evening. And remember, if you have not voted, vote now. It will take just 2 minutes. Thank you. Thank you so much.
Thank you. Thank you. Thank you.
Thank
Bye
you,
bye,
sir.
everyone. Bye bye.
Sir, Nitin, Nileshને કેવું છે to end meeting?
Nilesh, yeah, you can end meeting. Nilesh.
End meeting, Nilesh. Vinod? I think નથી, sir. Should I call him?
No, it's okay. કરશે લોકો as it is નીકળે છે ધીમે ધીમે. ચલો, okay. Good night.
Good night. Bye, sir.
Good night.